gosh, thank you, Peter. Those are very nice words, and it's certainly my honor to be here at Stanford. I really think of this as one of the premier academic programs in the country. This is my first visit to Stanford in any capacity, really. I've never been smart enough to get on the campus any other way, so I'm really happy to be here. And I don't just say that because Peter's a great friend, and Jay Carr and others are blossoming friends of mine. I really do think of this as one of the centers of the universe for rhinology in the world, frankly. It's a well-deserved reputation, and so my honor and privilege to be here. So as Peter said, I'll talk to you. This is really the story of my academic career over the next 30 or 40 minutes or so. And it has to do with an interest in evidence-based medicine that I had in the late 90s and into the turn of the century. And that's really where the story will begin. First, I'll disclose, probably the most pertinent disclosure in the research and the results that I show is that I'm biased in the sense that I'm a sinus surgeon. So I view the data through the eyes of a sinus surgeon. There's NIH funding for these studies. Some of that funding is here at Stanford. And I'm a consultant for a company called Intersect, although that really has nothing to do with the data that I'll be presenting today. Now, it said Tim Smith et al. On the title slide, and this is some of the et al. It doesn't even include all the folks who've been involved over the last 13 to 15 years, but all of these folks in some way, and more that I haven't listed here, including Karen Fong, who's in the audience today, have contributed to these works, and you'll see their names on some of the publications that I show. So let's go back to about the turn of the century. That makes it sound like it was a long time ago, but it was really, we're talking about 13 years ago or so, and there were some leaders at the American Academy of Otolaryngology, head and neck surgery, who'd caught on to this concept of evidence-based medicine, which really came to us in the 1990s, primarily from internal medicine. And they began to wonder, well, what kind of evidence do we have in otolaryngology to support many of the things that we do? And so they asked me and a few other folks from the American Rhinologic Society to set out and examine the evidence for endoscopic surgery in the management of adult chronic rhinosinusitis. And so we performed at that time what would be considered a systematic review, although we really didn't follow the strict methodology that folks follow today. But in general, I think we did a pretty good job of bringing all of the literature together. And you can see we really found primarily retrospective studies, as you can imagine. A few prospective studies were in the literature at that time, but really none of them had any type of controls or comparisons available. So our evidence grade was a C for endoscopic surgery in the management of adult chronic rhinosinusitis. So this really got some attention. I think we knew this, but to see it actually graded as a C began to make an impact on many people in our field. And we started, I think one of the knee-jerk reactions was, well, this evidence-based medicine thing is just another fad, and it will pass. Let's just keep doing what we're doing, and everything will be okay. But, as you can see, we talked about evidence in the conference today before we came over here. We never talked about, did we ever talk about evidence when we were residents? I just don't remember us we talked about the literature, we quoted certain studies, but I don't think we had the phrases that you guys use to discuss how we make decisions. We didn't have those phrases in our lexicon at the time, and now they're really routinely used. And I think we all know that we can't hide from it, nor should we. It's really our responsibility to determine what the best treatments are for our patients. That's probably one of the most important things we need to do as physicians, as clinicians. And if you look at our evidence, particularly through the scope of a 2000 review, I mean, we had a lot of room for improvement in our study designs. And so, interestingly, over the 1990s, especially the late 90s and turn of the century, we developed these validated disease-specific instruments, and we began to understand quality of life and how really chronic rhinosinusitis, if it's not a quality of life disease, what is? It was a great example of something that we as clinicians couldn't determine the outcome. We really needed to ask our patients how they felt after these various interventions. And then others suggested that perhaps there were other outcomes we should be looking at. In some of Dr. Kennedy's work, he suggested that patients who had an abnormal endoscopic exam postoperatively after healing, if they had ongoing mucosal disease, those patients were more likely to relapse. So perhaps we should be combining a quality of life instrument, patient-based instrument, with some type of objective clinical measurement that we could measure in our offices. And a task force was convened around this time, the Rhinosinusitis Task Force, and they really couldn't find consensus around this, but they state it seemed prudent that one would use at least one subjective is surgeon speak for, it comes from the patient, because of course everything they tell us is subjective, and objective is something that we as clinicians measure, right? And that we should follow these patients for at least 18 months, a relatively arbitrary target, that time frame. Well, we do have some data now regarding that time frame. More recently, we looked at what happens with quality of life after endoscopic sinus surgery. And you can see there are two curves here. One goes up and the other goes down. And these are just two different instruments that have a different measuring scale. And one, quality of life improves, the score goes up, and the other one, the quality of life improves, the score goes down, right? But notice that when we measured these somewhere around 6 months and then followed the patients out, they had this improvement from the intervention, and then that improvement remained pretty stable after 6 months up into about 20 months. So it suggested to us that if you're doing a study that included surgery, you probably wanted to study the patients at least 6 months. And if you really wanted to contribute to the literature, you would want to follow the patients longer than, say, 20 months, so we understood what happened after that. It'd be interesting to follow patients during this time frame too, to see where this occurs. This change really finally solidifies itself. It may be well before 6 months. Now, getting back to those outcomes, though, seemed prudent to use at least one subjective and one objective measure. And this really created a dilemma because of the lack of association between those two measures that we can see in patients. So let's talk about that a little bit. A number of studies are now published where a CT score, so an objective measure of disease severity, is compared with the patient's quality of life. And these are correlation coefficients. And you all know that a correlation of 1.0 is a perfect correlation. That means what you see on the CT scan, that's what the patient's going to describe to you in terms of what they feel. But we really didn't see much correlation between our objective measures and what the patients were describing to us. Interestingly, when we looked at two objective measures like CT and endoscopy scores in the clinic, there was pretty good correlation, about 0.6. It's a pretty reasonable clinical correlation. When we looked at one quality of life instrument, the rhinosinusitis disability, and we compared that to another quality of life instrument, we found a reasonable correlation there. They're clearly not measuring the exact same thing. Another interesting point. Not all these quality of life instruments, even though they're disease specific, are measuring the same thing. They're measuring a little bit different things. But if you ever tried to, correlate a quality of life score with one of our objective findings, we really couldn't find much correlation there at all. And so that led to this question, well, what does that lack of correlation mean? And I remember giving a talk, actually, Peter and I gave a talk in New York, so that must have been around 2004 at the American Rhinologic Society, and we discussed this phenomenon. And afterwards, a real leader in the field came up to me, and he said, okay, so which one's right? Is the quality of life right, or is it the CT? I mean, one's got to be right, and one's got to be wrong. So it was very confusing. It was very confusing to a lot of people in the field, these outcomes. And we started wondering, well, gosh, are these things just specific to the field of rhinology? But they're not. You know, if you look at obstructive sleep apnea and the RDI, if you try to compare that to quality of life, it doesn't really correlate very well. And it goes down all of these disease processes. So we face this, I guess, dilemma across many different disease processes where we might wish to measure a variety of different outcomes. Those outcomes aren't always measuring necessarily the same thing. And I think that's the point, that objective tests that we do, like CT and endoscopy, and patient-based measures, quality of life instruments really, they're often measuring different constructs, we call them in quality of life research, but different aspects of the underlying disease. Sometimes they're related, sometimes they're not really related, and they're very seldom equivalent. I mean, if they were equivalent, we wouldn't ever have to do nasal endoscopy in the clinic. If you thought about it, we'd just ask the patient how do they feel, and we'd go with that. But we know that sometimes the patient feels great, but we look in their nose and it doesn't look so good. And we feel compelled to say to that patient, I know you feel well, but we have to keep treating this mucosal inflammatory disease or it's going to catch up with you someday. There's a great deal of expert opinion to support that theory. And so we think that measuring both of these outcomes is actually pretty important. And these findings are not in any way unique to rhinology. We see them across many subspecialties. Now, before we get into the data, a word about averages or means. Here are those patients I showed you. They started here, we intervened, their quality of life improved, and it improved a little bit more over the next year. That's the mean. Here's the spaghetti plot of all 500 of those patients. So there's tremendous variability within this mean, right? We have to really think about that. I mean, what happened to this patient? They got worse, and then they got a little bit worse. Look at this purple patient right here. They got really worse, and then they got really a whole lot better. So there are other things going on. You can't just look at the means and think that you have all the answers to the questions is the point here. And I'm mostly going to be showing you mean values, right? So let's talk about some of the research that we've done to look at factors that might help us predict what these outcomes, and I say outcomes because we're interested in both quality of life and we're interested in the objective findings. And these were really the specific aims of the original study. First was just to measure quality of life and endoscopic outcomes in a prospective, multi-institutional fashion. We then were going to try to document preoperative factors very carefully and see if we could use those to help establish predictive models so that we could identify which patients were going to do well with surgery and which patients were not going to do so well with surgery. And then in a post-hoc analysis, we went back and looked at pathology and markers of inflammation and if those things could potentially help us to predict outcome. So this is a prospective observational study. We enrolled patients and we followed them at 6-month increments, and we really documented all of these things very carefully in a prospective fashion. We used Lund-Mackay CT scoring, we used endoscopy scoring, we used 2 different disease-specific quality of life instruments. So this is an exercise I always like to go through with the audience before we look at some of these data. So this requires some audience participation, whether you want to or not. This is always a harder talk to give at 7 in the morning than 7 at night, because no one will raise their hand to anything at 7 o'clock in the morning. So, how many in the audience, by raise of hands, think patients with polyps would be poor candidates for surgery? Okay, we got a couple hands there. How about patients with aspirin intolerance? How many think they would be poor candidates? So several more hands there.
So just poor candidate for surgery, or poor candidate for
I'm being vague here, J-Card. Don't, you just gotta listen to the talk, okay? Don't try to figure it out. Okay, how about allergy? Are they poor candidates? So a lot of hands up for that one. How about smokers? Poor candidates? A huge number of hands up, okay? How about depression? Patients with comorbid depression, so majority of hands in the room. So let's take a look. We'll see what we found. How do polyps, patients with chronic rhinosinusitis and polyps, how does this phenotype affect the outcomes of surgery? Well, if we look at their preoperative CT scores, this is Lund-Mackay, so the higher the score, the worse the disease, right? So patients with polyps had a higher score than any of the other subgroups that we looked at. We would all probably predict that, right? And how do you think they're going to look on endoscopy? Well, let's look at this, because we're going to look at this table a few times. This is preoperative endoscopy, ranked from, worst disease to better. Postoperative endoscopy, again, ranked from worst scores down to better. And then this is the change in endoscopy, the least amount of change to the greatest amount of change after the surgery. Now, we would predict that patients with polyps, because these scoring systems really heavily account for polyps, those patients have really bad preoperative endoscopy evaluations. But guess what? They also have really bad postoperative endoscopy evaluations. But if you look at the change in endoscopy, they had the greatest level of change or improvement in their endoscopic scores from preoperative to postoperative. So now let's look at quality of life. This was very interesting to me. Remember, we're looking at disease-specific quality of life for sinus disease. We're not looking at general quality of life here. Patients, their quality of life was actually, they had some of the best quality of life, these patients with the severest form of disease by CT scan, both preoperatively and postoperatively, and they had a huge improvement. So, their disease is terrible when you see it on CT and endoscopy, and after surgery, it looks pretty terrible too. But their quality of life, they actually start out pretty happy, and you make them even happier. So, the lesson here is if you're a surgeon, sinus surgeon, who just likes to ask your patients how they're doing and you never look in their nose, operate on patients with polyps. If you're the surgeon who has to have a pristine ethmoid cavity, what I sometimes tell my fellows is cosmetic rhinology, they're practicing cosmetic rhinology, these patients will drive you crazy, or potentially will drive you crazy. And there are other data out there to support that their quality of life outcomes, they get more improvement than the typical patient, but their objective outcomes tend to be not as good as some others. So the data support that. Now, aspirin intolerance. Again, very severe disease by CT scan. We would expect that because they have polyps by definition, right? Endoscopy scores, again, they're going to be some of the worst you see both preoperatively and postoperatively. They had a pretty substantial change or improvement in their endoscopic scores. But look at quality of life relative to where we were looking with polyps here a little bit ago. So all of a sudden you throw this aspirin intolerance factor into the equation, and their disease-specific quality of life plummets. And it's, some of the worst quality of life that we see postoperatively, and they got the least improvement in their quality of life with the intervention. Now, 12 points on about a 100-point scale is still a 12% improvement, and that's considered to be a fairly substantial improvement in quality of life from a clinometric standpoint, but still, it was the least of all as compared to all the other groups. Now, here the data are just a little bit mixed. Most people have suggested that their outcomes, they don't get as much improvement as other folks do from surgery. Dr. Kennedy's trialogical thesis from 1992 suggested that it wasn't worse. This is primarily retrospective. These are prospective studies, so they probably trump the, sorry, Dr. Kennedy. Just keep it. What happens at Stanford?
Being recorded.
Okay, that's right. This will be on the web. He'll call me tonight at the Brazilian barbecue.
And is this 1 year, 2 year?
18 months. Yeah, so actually the average was 20 months. Our target was 18, but our average was 20 months. Now, allergy and smoking, these are kind of interesting. I mean, they're both, you could think of them as environmental irritants, I guess, and they behave somewhat similarly. Sort of average disease on CT scan. Not looking as bad on endoscopy as you might think. I've wondered about the smokers, and I have some theories about that, but I'm not going to get into that right now. But look at their change in endoscopy. The smokers had the least amount of change in their endoscopy score. In fact, it wasn't even significant statistically anyway. Now this could be a sample size problem because it's hard to find smokers in our patients who have chronic sinus disease. It makes sense. They've got airway disease, they feel miserable, and for the most part, they've given up smoking by the time they get to us and we're doing surgery on them. Quality of life-wise, again, they tend to be on the better end of quality of life, and they have pretty substantial improvements. I mean, 17-point improvement in the smokers. So both groups have moderate disease. Their quality of life changes are significant, but sort of middle of the road. The underlying message is that smokers seem to do okay. The literature has been very mixed on this. There was a lot of literature, 1992, again, Kennedy's thesis, and then this 2004 study. These were primarily retrospective studies, and they really suggested that smokers don't do well after surgery. In fact, I think even at the University of Pennsylvania, there was a time when Dr. Kennedy would not operate on someone if they were smoking. So he felt that strongly about it. So this really surprised me when we found this, and then was repeated at the Medical College of Georgia. And I began to wonder, well, why the differences in these reported outcomes? Does it have anything to do with the volume of smoking? Are we seeing different patient populations who are smoking more or less? We just called them smokers, but maybe some are half a pack a day average, and in another cohort it's a 2-pack a day average. And are we measuring different outcomes? And that's what I think is going on to some degree. So we found that quality of life outcomes didn't differ between heavy, that's 2 packs a day or more, and light smokers. So there really wasn't any difference there. But we definitely saw worse post-operative endoscopy scores in the heavy smokers relative to the light smokers. So when you look in their nose, they have that very erythematous, more friable looking, unhealthy mucosa in the nose. So I think it's important that when you have these debates, you have to clarify a couple of things. Number one, how much are they smoking? How much is that cohort smoking compared to this cohort? And number two, which outcome are we talking about? Are we talking about quality of life, or are we talking about what their endoscopic exam looks like? Allergy, the literature is also mixed on this, but the more recent prospective data seem to be suggesting that allergy doesn't really impact our outcomes of sinus surgery. There is a fair amount of retrospective data that would suggest that, but if we look at it prospectively, it doesn't appear to have a huge impact on it. Now, depression is very interesting, and of course, depression probably affects every disease. It certainly affects chronic rhinosinusitis. Look at the patients with comorbid depression. They had the least amount of disease on their CT scans relative to all the other cohorts. Endoscopy in the average range. Look at quality of life. Again, this is the patient's perception of their sinus health, right? And they see themselves as having the worst quality of life. And guess what? It's both preoperatively and it's postoperatively. But the interesting thing is they really had quite substantial improvement. They're still miserable, but they're at a better level of misery. So this has actually helped me a lot in terms of counseling myself and the patient before I go in to see them. I mean, you have to set your barometer right with these folks, and you have to keep things in perspective. Because if you just ask them how they're doing, this is what they're going to tell you. If you ask them how they're doing relative to surgery, relative to the way they were doing before surgery, hopefully this is what they're going to tell you, the change, the improvement that occurred. But they're not necessarily going to have this tremendous quality of life and, you know, that ray of sunshine that keeps you going in the clinic. So, and if you look to the literature supports this. You know, across the board, pretty much everyone has found that depression really has, not just, it has an impact on everything. Cardiac disease, you name it, it has an impact on outcomes. So, remember, the aspirin intolerant patients have polyps and they have asthma. I mean, this was a very gross categorization I did here, but it helps you get a sense for what's happening in these various subgroups of chronic rhinosinusitis. When we threw it into our algorithm and looked to find out which factors really were impacting quality of life, we found two were impacting outcomes. Number one, aspirin intolerance, and these patients appeared to have less improvement in their endoscopic exam, and they had less improvement on one of the quality of life measures, and it trended towards that in the other quality of life measure. And then depression. It really had no impact on their endoscopic outcome, but it predicted less improvement in their quality of life outcome. So we thought, okay, we might have a couple of factors here that can help us in terms of counseling folks. Then we took this and blew it up into a multi-institutional study where we gathered about 700 patients, including patients here at Stanford. And we really found that none of these factors fell out of our models anymore. None of these phenotypes helped us to predict outcome. They did, however, help us to predict their baseline quality of life. And I think the patients with depression show this the most clearly. They start out, you know, down here with their quality of life before surgery. And all your other patients who are not depressed, they start out up here with quality of life. These folks, of course, improved to this level. These folks also improved almost to the same degree. It's just that they don't even get to the level of the preoperative status of your patients without depression. So that helps me to think about those patients when I'm talking to them and when I'm trying to decipher the messages they're sending to me in the clinic. So we thought, okay, so now what? And we learned, now I've spent, I don't know, 8 years, and we don't really know all that much more than we did before. What about the inflammatory characteristics in the mucosa? And a lot of people around the country have become more excited about this, especially the eosinophil. And it was interesting, when we went back and we measured mucosal, so tissue levels of eosinophilia, if we saw more than 10 eosinophils per high power field, the chance of the patient having a significant, what we would call a clinically significant improvement following surgery was 56%. If they had less than 10 eosinophils per high power field, that jumped up to the 75% range or thereabouts. Now this is a pretty rigorous definition of improvement. A much higher proportion improved than this. This was a pretty rigorous level of clinical improvement that they had to reach. And then we found sub-epithelial edema, another pretty gross histologic finding, was somewhat predictive of outcomes of surgery. So I think in the future, we recognize really now that these clinical phenotypes that we've held so dearly, chronic rhinosinusitis with aspirin intolerance, these are really pretty gross categorizations, and there's a marked heterogeneity in disease severity and outcomes even within these phenotypic groups. And there are clearly more sophisticated measures of disease and disease severity, and even more sophisticated molecular markers of disease. And the genetic underpinnings there are probably where the future lies in this field. So while we were doing this, the guys at the Cochrane group were reviewing the evidence of endoscopic surgery in 2006. And they came out with a Cochrane review that stated what that first bullet point says. Endoscopic surgery does not confer additional benefit to that obtained by medical treatment. So that one hit the side of the ship pretty hard, right? I mean, that guy, they thought our study got attention when the Cochrane group says, by the way, what you guys do really doesn't matter. Well, this was based on 3 studies, and this is the weakness in Cochrane, honestly. They only look at randomized controlled trials, and there were 3 randomized controlled trials, and none of them compared surgery to medical therapy in patients who had failed a substantial triad medical therapy, what we call in the clinic maximum medical management, whatever that is, right? So these studies don't even address the disease process that we treat with surgery in the United States. I mean, you wouldn't be meeting the standard of care if you took someone, didn't offer them any medications, you took them to surgery. So a group of us at the American Rhinologic Society decided, well, we can't really randomize patients to surgery and medical therapy for a number of different reasons. We can talk about that if you want to. But we can follow patients after we've treated them with some definition of maximum medical treatment. In this case, it was 3 weeks, at a minimum, 3 weeks of culture-directed or broad-spectrum antibiotic and topical steroid therapy. Now, in reality, 90% of these patients enrolled in this study also got a course of oral steroid therapy before we called them failures of medical management. Now, if you take this group of, these people, about half of them, interestingly, decided that they were going to undergo endoscopic sinus surgery, and about half of them decided they were going to continue with medical therapy. I mean, we gave them a choice, we counseled them, and they self-selected into a pretty nice little, very biased study. And when we looked at their CT and endoscopy scores at baseline between these 2 groups, I mean, what would you have thought? The ones who chose surgery would have a lot worse disease, right? Well, we didn't see that. We didn't see any differences in their baseline disease severity. But as we followed these patients, it was pretty clear that the patients who underwent surgery had substantially more improvement in their quality of life relative to the patients that we continued to treat with medical therapy. And perhaps even more interesting was the significant reductions in antibiotics, systemic steroids, and missed school and work days in the surgical cohort. So these are important outcomes that we've not really talked about yet. What I found fascinating is that if you follow these 2 groups over the course of a year, about a third of the patients, let's call them the crossover cohort, they're the dotted ones here, about a third of the patients initially enrolled in the medical treatment group crossed over and said, okay, enough, I'm going to have surgery now. And if you watch their quality of life, they had this initial worsening of quality of life, and then at some point in this 1-year time period, they elected to undergo surgery, and we measured them at the end of that time frame. They again achieved improvement in their quality of life. So now it's sort of a crossover study, completely unintentional, and just happened to occur, so we observed it and published it. Now, beyond these outcomes that we've discussed, I started to hint at other outcomes that are becoming more important. And if you read about the Affordable Health Care Act and all of the money that's put into research looking at where medicine is headed, you're going to hear things like health state utility values and quality adjusted life years, QALYs, and then cost effectiveness. And these things can be used to really help make health policy decisions. What's worth the If we only have so much to invest in healthcare in the United States, what's worth investing in? Well, it's the things where we get the most bang for our buck. That's the underlying premise, right? So let's compare the health utility values of patients with chronic rhinosinusitis at baseline to other disease processes. I mean, where do we fall in that spectrum? Now, health utility, that's how we all perceive our current state of health, and it's a number between 0, dead, and 1.0, perfect health. And by the way, the average in this room in the United States is 0.81. That's where most people rank their current health utility. Well, patients with chronic rhinosinusitis fall in at 0.65, adjacent to moderate asthma and Parkinson's disease and coronary artery disease, right? I found it interesting that hearing loss, are there any otologists in the room? Dr. Jacko left town because he did not want to see this slide. Hearing loss is in the moderate degree. I mean, they're almost at where the average patient rates their utility. And the last time I checked, Medicare wasn't paying for hearing aids, right? So there may be some reasons behind that, and I'll back that up a little further. So now we can measure the change in someone's utility with an intervention. So what this allows us to do is compare, well, how much more utility do you get out of endoscopic surgery than hip arthroplasty? Because we can only fund, so much of this, right? So with primary endoscopic sinus surgery, the change in utility is 0.09. That seems low, but here is the value that's the critical value. That is the value that most experts in econometrics say if you increase utility by more than 0.03, that's a substantial increase in utility. Notice how hearing aids fall below that line. And the last time I checked, Medicare wasn't paying for hearing aids. So there really may be some more methodology to this madness than we think. I also found it interesting that revision endoscopic surgery did not improve utility as much as primary endoscopic sinus surgery did. And that may have to do with just selecting the patients with the worst forms of disease are probably the ones more likely to get revision surgery. So it just may be a selection bias there. Now, perhaps even more fascinating to me is that it's not just surgery. It's the post-operative medical management over the long term. When we say long term, I mean 5 to 7 years we've measured this. But notice over time, over 3 years, they begin to approach the U.S. norm for utility, and at 5 to 7 years, we've brought these patients, on average, back to the norm of health utility value. This isn't published yet, but is under peer review. These data like this are under peer review right now. And this is where we took those utility values and we converted them to quality adjusted life years, and we performed a cost effectiveness evaluation of endoscopic surgery relative to medical therapy. So the cool thing about my career is that I couldn't do this, what's on this slide. I don't have the expertise to do this research. This was done primarily by these three guys, and especially this guy, Luke Rudnick, who after fellowship, he did a fellowship with me a few years ago, and then he went to the London School of Economics to get a degree in health economics. So he understands this Markov decision tree and all of these modelings that you do to do this. And you've seen Zach Solar on 10 of my papers, and he got a master's degree while he was at Harvard doing his fellowship in genetic epidemiology. I don't even know what genetic epidemiology is, but I always tell them, my data is there for your taking, run with it. And that's what they've done here. So this is a cost effectiveness analysis from the U.S. government payer perspective, not from the society perspective, because there are different things you measure. I mean, society values things differently than the U.S. government does. And the conclusions are that the costs of endoscopic surgery plus ongoing medical therapy over a 30-year time period cost this much and produce 22 and a half quality adjusted life years. And medical therapy, just continuing medical therapy across the course of a lifetime, costs this much and produced 18 or 19 qualities. And when you do this sensitivity analysis, it concludes a 95% certainty that endoscopic sinus surgery is more cost effective than just telling those patients to continue medical therapy over the long term. Now, these are tough studies to do. Most of these types of studies are based on data that come from randomized controlled trials, and we just don't have those kinds of data in patients who have failed medical therapy. So a number of different assumptions are made. Revision surgery is not included in this modeling. It's just too difficult for us to include that. There's not enough known about revision surgery, how often it occurs, and the like. So this doesn't apply to all of the patients with chronic sinus disease, but it's an interesting perspective, I think, on the disease process and our treatment of it. So to conclude, I would say there's evidence supporting endoscopic surgery for chronic rhinosinusitis, and we've seen that, you know, on average, patients improve in both quality of life and in their endoscopic scoring with endoscopic surgery. Our next frontier really, I think, in the outcomes world is comparative effectiveness, and we're going to be incorporating economic outcomes or econometrics into those studies. In terms of predicting outcome, you know, our beloved CT scan that we've held on to for so long and we think gives us so much incredible information about how this patient's going to do long term, as it turns out, it's not really very predictive of how a patient's going to do over the longer term. And I'm still surprised because I find myself still trying to predict how patients are going to do on CT scans. I still hold it close to the heart, and I get burned on a weekly basis. Clinical phenotype doesn't really help us predict who's going to do better or worse, but it does seem to help us predict what their baseline quality of life is going to be. And that can help us counsel patients and counsel ourselves when we're treating patients who are particularly challenging to treat. And I think the next frontier is in cellular, molecular markers and the genetic underpinnings. So those are my comments. Thank you for having me again. That really tells the story of about the last 13 years of my career. And we're continuing, it's not me continuing, but it's folks that I've been able to work with who've entered my professional life who are continuing to drive this forward. And I hope you'll see a lot of work out of them to clarify this as the years go by. So thank you again, and look forward to any questions or comments that you may have. Yes, sir.
Since I've stopped doing sinus surgery, referred patients for sinus surgery. There's one particular sinus surgeon in the area who, when he first started 15 years ago, was operating on everybody I sent him. Now I've noticed over the last few years, I would say maybe 10% of the patients that I have done medical treatment for and felt that they were a failure, that they needed surgery, are now being operated on. Now, is that an outlier? The longer you operate, you tend to operate less?
Yeah, it's interesting. I've thought, it's an interesting question. I've thought about that. I mean, in some ways I feel like I've gotten more conservative over the last 15 years, but then there are certain patient populations where I feel like I've become much more aggressive earlier with those patients. An example of those patients would be patients with, you know, severe hyperplastic sinus disease who grow tremendous polyposis, and we do, let's say, frontal draft 2A procedures, widely open things, and then they rapidly recur polyposis in the frontal recess and the frontals and continue to sustain mucosal inflammatory disease, that's a patient where the next time I take them to the operating room, I'm probably going to do a modified Lothrop, so I'm going to open the entire floor of the frontal sinuses. I've noticed we just had a conference on patients who have recurrent acute sinusitis, and I've noticed I've become, if anything, a little bit more aggressive with that patient population, but I heard just the opposite from very seasoned sinus surgeons in the room who actually avoid operating on these patients at all costs, which, their perspective befuddles me, and my perspective, I'm sure, befuddles them. So why is that? I mean, I think we're both being honest about what we're seeing, and I certainly don't want to operate on a patient and not make them work, not make them better. That's the worst part of our job. So, I think in the end, there are certain areas where I've become more conservative, and I think there are certain areas where I've become more aggressive. I think maybe we used to, I don't mean to belabor this question, but it's an interesting one on many levels. I think we used to think of this more as an infectious disease, and we just had to get the right antibiotic. And so we were probably operating on way too many patients because we weren't controlling their inflammatory disease well. And I think now we really recognize this is an inflammatory disease, and we're much better at treating that inflammation. And so perhaps we're sparing a lot of patients surgery because we know that steroid trial can make all the difference in the world. Yes?
When you show that graph that shows the CLAD scores going up and the patients that were treated with sinus surgery and going back to normal,
Yeah.
do we have the same data for patients that were treated medically long term? Is that even possible to get?
It's possible to get, we just don't have it yet. Those patients, my initial study, my initial grant, the one that Peter and I have been working on since about 2004, those were just surgical patients. And our last grant that we got, 2008, 9, 10, 11 maybe, it's medical and surgical patients. So about 3, 4, 5 years from now, we'll have it for both. I can't wait to see that too. I mean, it's going to be an interesting group to follow. Jacob.
So of course, it's just a comment that this work has really impacted how we can counsel patients, how we can work with insurance companies, and it has so many ramifications in telling, into kind of just prognosticating to some degree who is going to benefit from this and how we can also justify some of the things that we proceed with in our practices. So thanks for those contributions. And also, I just want to get your thoughts on early outcomes, on your thoughts on the early outcomes research that's available for balloon sinuplasty. For the group, just from an expert in this area of outcomes, what are your thoughts on what's out there?
Yeah.
What is kind of like?
Yeah, it's a good question, and I struggle with it. I mean, I think in some ways, some pretty reasonable studies have been designed, but I find them sometimes difficult to interpret. Precisely what outcomes they're focusing on, for instance. In the end, I feel like it's a tool that's meant for a few subpopulations in this disease spectrum that we treat, but it's being applied to the entire disease spectrum almost. And so that is just right out of the gates, that seems to me to be a fundamental flaw in some of the research that's been presented. But there's been two fairly interesting studies recently. A randomized controlled trial, the abstract was presented at the ARS. I don't think I sat in on that particular presentation, but in reading the abstract, they found, well, I'm not even sure I know what they randomized in that study, but look for it. It'll likely get published somewhere. And then, I think it was in the journal Rhinology in Graz, Austria. They recently did some type of a randomized trial of balloons, and they discontinued the trial after a few months because the patients who were getting ballooned were clearly not having as good an outcome as the patients who had more typical surgery. Now, there are a lot of subtleties, I'm sure, in both of these two studies, and they really need to be carefully dissected.
So the jury's still out for
I think it is. I think it's still out for me. But I've never thought of it as a procedure to study. I've always thought of it as a tool to use in certain situations. So it would be like randomizing someone to a microdebrider versus through-cutting forceps, or something like that. I mean, we wouldn't do that, right? We think of the microdebrider as a through-cutting tool, and we use it as such. So this is a way to increase the size of an ostium. It's another tool that increases the size of the ostium. So, I don't know. I see it as something we'll be using in our offices, so it'll be an office-based approach more. In a tertiary clinic, I could see us using it to dilate stenotic frontal recesses or frontal ostia. In the primary cases, I could potentially see it being used to treat things like recurrent acute, or how about an odontogenic maxillary sinusitis where the tooth's been pulled and the odontogenic aspect is cleared, but the sinus is just too sick to clear on its own. Wouldn't you love to stick a balloon in there, irrigate the thing out, dilate the ostium a little bit, and see if you could resolve it that way? So I do think there are uses for it. I'm just not sure. There's a little bit too much bias, I think, in the studies, unfortunately. Not to say that there's not bias in the studies that I've just presented. I mean, that's one of the huge things I think we face as we try to interpret the literature on a number of different things. Okay, well, thank you all. Appreciate it.